Good afternoon, everyone. We're here for discussing the future of skin quality, what will replace traditional. No, that's done. Sorry, that just went by. I think we have to go to the next session. Yeah. Biostimulators redefined from polymers to polynucleotides in regenerative aesthetics. And who else to open this session? Opening batsman with Dr. Lim Ting Song, who actually, I think, has pioneered polynucleotides and stormed the scene with it. So,
Thank
from
you.
Malaysia, very well known to everyone, wide experience. Here we go.
Thank you very much. So we heard earlier, I think there was the session about skin boosters. And these are my conflict of interest statement. Basically, what we've seen is an evolving injectable scene in our aesthetics. So there was a lot of experimental injectables in the early days where we tend to mimic what we do with surgery. Basically, we are enhancing, thinking that we're giving almost like an implant. But because of a lot of complications and long-term problems with it, we narrow it down to something that's safer. And that's where we get hyaluronic acid becomes something that is big in the scene for a while. But we also know there will be limitations and safety issues with hyaluronic acid fillers, especially if you want to mimic like an implant, like what you can do with surgical implants. So therefore, people are looking into, are we really doing the right thing? And therefore, we have moved on to try to see how we can actually improve the function of our tissues. So we know the early days where we use silicons, we use collagen fillers, that got into trouble. There was once people look into collagen stimulators. At one point, people are playing with it, but still end up with the same concept of filling. Even though they are polymers, they think that this polymer works. But of course, with complications with granuloma, people move on to hyaluronic acid, which seems to be better in terms of not giving so much trouble. Of course, with huge amount of using of hyaluronic acid, you have overfilled syndrome, you have also nodules and stuff. So people go back and say, okay, let's go back to look into biostimulators. But the real thing is biostimulators are also polymers that don't really create the same kind of tissue that we want. So when we talk about skin quality, I think earlier people talked about skin quality. We look at these four different quadrants: skin tone evenness, skin surface evenness, skin firmness, and skin glow. But skin is just merely just the surface of our ecosystem, our ECM. And this ECM, this extracellular matrix, is a continuum of connective tissues that span between the skin, the fats, the muscles, onto the bones. So the more we look into it, the more that we feel the extracellular matrix plays such a big role into maintaining tissue health. And this is actually used as one of the emerging for hallmark of aging because it is the deterioration of ECM that leads to aging, including the skin. But how does the ECM look like? When you cut the skin, you realize there's a lot of connective tissues from the skin connected down to our tissues beneath them. They are empty space. So it's very different from your cadaver. In the living tissue, our tissues are not dried up. And therefore, when you look into the connective tissues, they are lubricated with your glycosaminoglycans. There's a lot of empty space in between them. Unlike what we used to think, where we used to think that in our tissues it's all layers. After the skin is always fat. After the fat is always muscles. After the muscles is the bone. And we think it's all filled up. But in real life, there's a lot of empty space. We call it interstitial space. If you glide with a cannula, you realize there's a space for you. We are not in between the fats. We are in the interstitial space. And this particular structure that holds the tissue together, they are constantly moving as if they have life on their own. And in between, sometimes you can see cells migrating in this particular structure. And this structure, when it moves, it never goes back to the same place. And not every structure looks the same. Every single them looks different. It's not like your retaining ligament. People like to draw that tree. That's not true. Because retaining ligaments is merely just a bundle of them that becomes thicker. There's no one thing like a tree there, but it's everywhere, just like a spider web. And the cells actually stays in there. This video was taken by a hand surgeon in France called Jean-Claude Yimbat that started filming it since 30 years ago. And what he proposed is this structure that is built up of tissues. All the cells live in between them and connected to them. Because without this, we don't have shape. The shapes are not coming from our tissues. The shapes are coming from connective tissues. So people used to think that all our volume is due to our fats. That's not true, because it's this tent that holds them together. So if you look into the lobules, there's a lot of holes in there. There's a lot, and these particular structures extend from the surface down beneath. Like I said, it's constantly moving. There's a lot of cells in between, as you can see here. There's a cell migrating in between them. This is called either one of the cells, fat cells, migrating, or it could be a fasciocyte, which is the one that lubricates the whole ligaments and the whole connective tissues. So if the cells and tissues are not the ones that make up our volume, and it's these connective tissues like work like a tent that allows a lot of space in them, is making up the volume, why are we filling up the tissues, thinking that it's reversing aging? Because it is not the bones that build the structures. It's your body that holds the bone together through a hydraulic system called tensegrity. Without your soft tissues, the bones just lie flat on the floor. They won't stand up. It is this hydraulic system that has a lot of empty space that builds them. And it's this particular structure that made out of collagen type 1, type 3, type 4, type 6. In majority, of course, there's a lot more collagen in there, and all the proteins that plays a big part. For instance, your daccharin, making sure that it actually makes into the shape that you want. Also, you know that it's all connected to cells. Once you bring the cell out of your connective tissues, they are not the same anymore, because cells will only behave the way that it should when it's attached to the connective tissues through your integrin into the cytoskeleton, and it tells the nucleus to do what it has to do. But with aging, of course, these connective tissues get disrupted, it becomes fragmented, it becomes hardened. So daccharin was supposed to help to rebuild them. But of course, with this dysfunction and everything, you get hardened tissues. We call it fibrosis. Part of aging gets you fibrosis. But if you put a foreign body in there, you can stimulate fibrosis. That is where we want to rethink when we talk about biostimulators. Not all collagen that you stimulate is good for the body. Fibroblast hyperactivities cause hardening of your connective tissues that no longer works like a gel dynamic tissue. We need this dynamic tissue to move, to redistribute your pressure on the body. When you have hardening of your connective tissues, energy doesn't flow, your blood doesn't flow, your lymphatic drainage got stagnant, and also in impingement of nerves, you get pain. People who have cesarean section tend to have back pain much more. Not because the pain comes from the scar, but it's the scar blocking all the flows that affects the flow to your back. Similarly, when we actually do overdoing stimulation on your skin, what happens? You deteriorate the tissues and you get skin sensitivity. Even though you think you are getting tightening, it's a tissue retraction. It's actually scars that you don't see. You can only find out later on where they actually have expedited aging or their skin quality drops. So when you damage the ECM, you alter the mechanotransduction, you cause more senescent cells build up more senescence-associated secretin phenotypes, you get more damage in the ECM. It's a vicious cycle. ECM is more important in cells. This study shows you when you put the young cells in the old ECM, the young cells get older. That means young cells doesn't make the ECM younger. But if you put the old cell in a young ECM, the old cells get younger. So whenever we think about trying to put fillers or implants or biostimulators, thinking that we are doing good things, maybe you want to rethink. Are we creating more fibrosis on the skin and give them more volume? So now people will ask, since you are so afraid of using all these biostimulators or implants or fillers, what are the alternatives you have? I'm not saying they are bad. Okay, almost done. Okay.
Thank you.
I'm not saying that it's bad, but I'm saying that we need to be cautious because when your ECM not healthy, you can actually cause more problems. And what we need to do is to put things that helps you to rebuild your ECM. For instance, polynucleotides. This is after one time. It actually helps in terms of, because nucleotides itself is energy, and it helps to revive your nucleus function. And this is where we see tissues get better. And the thing is, I actually use cannula because the more puncture you do on the skin, you might actually destroy them, more fibrosis. By placing it without much of cutting and puncturing to the skin, you can actually create more improvement in terms of ECM. And what we see here is improvements with exosomes. And I think speakers here and also the moderators are so a big fan of exosomes. As you can see, exosomes can improve your extracellular matrix, reduce inflammation, and improve skin quality. The other thing that we also see is without doing subcision, if you place exosomes around the tissues, it heals them. It actually improves your scar tissues, your hair follicles, your scalp health, and also if you actually place them with collagen replacement therapy. Why so? Because collagen made out of the ECM, if you place small amount, spread it around, let this collagen fill up and become raw materials to help our ECM to become healthier, you can see improvements of skin quality. And in the end, what we want to achieve here is to make our extracellular matrix healthier again. With that, thank you very much.
Thank you, Jing
Okay.
Always not enough time for him because he introduced many things, many good ideas. Really appreciate. I'm introduce next speaker. Next speaker is Thai, is Kungwalapiat Pitusun. Introduce, she explained about the next generation biostimulator, current concept, and the future directions. Please.
Thank you for introduction, and it's my honor to be here again. Okay, let's start with the next generation biostimulant. I'm gonna put drawing like a current concepts and future directions. So this is my disclosure. So the current concepts, as Dr. Previously said, that now we are focusing on the ECM and the dermal layer, especially the fibroblasts and the extracellular matrix. So the current biostimular trying to stimulate the functions of the dermal fibroblasts and also trying to fill mechanical filling of the defective tissues, trying to inhibit the collagen degradation, repair the dyspigmentation, and trying to improve the skin barrier. But the future directions are shifting. Now we are focusing on the microenvironment, not only some cells or some parts of the skin tissue, but trying to focus on all the environment of the skin, trying to restore both architectural and also try to enhance the cellular activations and trying to focus on the other important layers or the important cells. Let me get you some example in these topics today. So let me conclude the next generation of the biostimulator into three categories: the material innovation, the molecular innovation, and the indication innovation. So let's start with the first thing, the material innovation. What is this? So this is the example of the particulate biostimulators that we already have in the market right now. You can see that each kind have a different structure, different shape, and also different size. And what does it implicate in the clinical? This is the example of the solubility of these polymers. You can see that PLA, the irregular shape, all with the porosity have different solubility at each time point. And also the PDLA with porosity or solid microsphere. And we all know that different in terms of particle size, particle shape, and the crystallinity result in a different of the distribution, the hydration and suspension, and also implicate with the aggregation, degradation, which leads to the different intensity of inflammation. And these difference are effect leading to the difference in terms of efficacy, the sustainability, and also the complication. And this is another example of the innovation. We already have the microsphere of PZL, but right now we also have the fully solubilized PZL with CSAP technology. I would call this as the innovation of the thing that we already have. And also, what about the HA? The classic HA that we already have is one of the, I would say, a classic and a very good tools. But what we enhance this ability or properties of the HA that we already have. We can put the bioactive glass, put like some of the component like a recombinant collagen or copper dot bioglass, or put a polymer into the HA that we already have. However, these examples are only based on a cell-based design, especially the animal wound model. But this is also the example that we can do with the classic HA, that is not a feeling effect anymore, but it can communicate or stimulate the cells. And also, this one, another example of the HA. And also, we already have like other source of polynucleotides. It might not need to be a fish-derived PN, but we can extract with the plant-based PN, and it might act as well as the salmon-based PN also. And also, we already have the particulate human acellular dermal matrix is another technology that we invent, and already have the human tri with the RCT tris, and can show us that it can stimulate the fibroblast proliferation. That's the example of novel agents. Okay, let's move on to the molecular innovation. What is a novel biostimulators or innovation? This is only the example. I know that the biosimulator that we currently have in the market, some of the biosimulator can have property to stimulate the elastin production, but we also have some of the technology that focusing only the elastin, like this one. What about we encoding the precursor, the elastin precursor, we should call turboelastin, with the mRNA technology and implant into the skin? It can stimulate the elastin production. What about we put we cross-link the recombinant human turboelastin with the HA? It also can stimulate the elastin production. This I would call like a novel technology that one can do more. And what about we draw the concepts of genomic-based treatment? This is only like a more in the topical form, but we can draw this concept into the biostimulator, especially in terms of injectable forms. This is the table, the summarize of the concepts like senolytic, xenomorphic agents, mTOR inhibitor pathway, or epigenetic regulators. We can drill these concepts into the injectable biostimulators. I believe that one day we will reach here. Okay, the last one, the indication innovation. What about we have a new target for the agents that we already have? As I already say, the future direction is trying to focusing on other cells, other components of the layers. So, fat layer is gonna be a next hero of the era because we already know that fat cells can function as an endocrine and paracrine organ. It can affect and modulating the fibroblast activity, the angiogenesis, and also modulate the immune response. Recently, we have quite a few numbers of papers reviewing about the injectable biostimulator effects on adipogenesis. And this is the summarize of the proposed mechanism of actions and a key factor or signaling pathway. You can take a picture and read it back. We can have the evidence that PLLA, PDLLA, PCL, even HA can do something with the adipogenesis. Also, CAHA combined with the autologous fast injection, or we already have a technology that say adipose ECM-derived scaffolds or Renova also can replicate the composition and stimulate the adipogenesis. Even the PTRN, and also we're going to publish another paper about the PN effect on adipogenesis also. Don't need to say about the PRP exosome. We have some of the in vitro evidence already that it can activate the adipogenesis. This is what we call an innovation. And this is thank you to the AI. It can do better than me. It can make a nice infographic here that summarize the pathway, the proposed pathway of these biostimulator on adipogenesis. What about bone? Bone is not a new thing. Actually, in the orthopedics field and also dental field, they have been focusing and studying on the bone more than us. But we now gonna shift the direction of the biostimulator into the bone layer. And also, thank you to the AI, which summarized the pathway, the proposed mechanism of the biostimulator or biomaterials on activation on bone regeneration. So, at the end, I would say that the next generation of biostimulator, we are looking for the biomimetic biomaterials that can not only mimic or simulate the normal tissue, but also can act of or function as normal host tissue. Thank you.
Thank you, Dr. Pintuson. Yes, Pintuson. Please come join us. And you really covered it very extensively. Thank you for that. And now it's with pleasure that we call upon Dr. Rosalind Kuprivat.
Thank you.
And she's
Exactly.
here to talk about from inflammation to integration, scientific determinants for selecting polyester-based biostimulators. A very long topic.
Thank you very much for the introduction. So, hello, good morning. My name is Dr. Rosalind Kabiwat. I'm a dermatologic surgeon from Thailand. I'm the head of the Department of Anatomy at the College of Integrative Medicine in Durgit Bandit University. And I have no conflict of interest in this lecture. So as we know, cutaneous aging, I think everyone knows, it's about the fibroblasts, about the reduction of the collagen, of the elastin, of the ECM production, of course. And I just want you to see like a big picture, like the fibroblasts are normal, the young fibroblasts, it has this large cytoplasm, it has these ligands, it can move around like pretty much freely. But when it's come to aging fibroblasts, it collapses. the cells gets collapsed, the cytoplasm collapse, and they don't have that much of a ligands to actually move around. So that's why the production of the collagen is much less. The collagen that you get from the normal fibroblasts, you get like a densely packed, nice strip of the collagen, but in H fibroblasts, you get a ripple, you get a fragmented kind of fibrin. So that's why it's the total skin lose the integrity. So the concept of biostimulation is not just injectable biostimulator. Biostimulation is basically a concept where you stimulate the fibroblasts. You do anything to stimulate the fibroblasts to induce the collagen productions. So there are terms in some literature, they call it a laser biostimulator. You can use laser because, of course, laser can induce fibroblasts to stimulate the collagen production. So it's not limited to just injectables. That's the key. But however, overall, all the biostimulator, we know that it's come up to this one simple pathway, like the wound healing pathway. It's all just going to affect somewhere in the cascade of the wound healing. Depends on the materials itself. It can act in different cascaded according to this pathway. But today I'd like to really focus on those polymers, polyesters, the PLLA, PCL, and the PDO, which is we use a lot these days. Sorry. So for when we talk about polymers, polymer is a big thing. It's anything that has a same looking and then you have it in a long chain. That's how we call it polymers. So polysaccharides is also polymer. HA is also polymers. So polyesters, that's a subset of a polymer. And in polyester, that's where you have those PDO, PDLLA, PCL, those biomaterials. We call it polyesters. Okay? And the process of the wound healing, as I already mentioned, start with platelets, and the macrophage comes, and then after that, it stimulates, sends signal to the fibroblast, and then you get all the collagen productions. But is the high signal is actually good for your skin? The answer is no. If you have too much wound, if you have excessive inflammation, excessive scarring, as you can see, it's reduced in terms of the collagen production. You, instead of getting a matrix remodeling, you get a scar tissue. So that's the key when you want to choose a certain biostimulator, especially those liquid biostimulator. Because if it's laser, it's just one-time wound, and then it stops. But with liquid, with those injectables, it stays in your skin. So it's going to last longer. So you have to match the potency of your biostimulator with your patient. If you have a patient, not so much aging, but you add in a lot of biostimulation, a lot of inflammation, you're gonna get like a soft scar or stiff kind of skin, which is, come on, it's not that natural. But if you have like a really aged patient, you have like 80 years old patient, and you give them like a really tiny signals, it's not going to reverse the aging. It's just going to feel like they look the same. So you pretty much have to find something that is comparable, that's pretty much good enough for your patient. So choosing the biostimulator is not just about the level of the inflammation. You need to match with the patient. You need to choose the right biostimulator. And once you choose the right biostimulator, you're going to need to use the right injection technique, of course. This is my table. I did it almost all of the biostimulator we have here in Thailand. Actually, there's more. It just keep coming in. It's just a little bit too much. But as you can see, I just want you to see the big picture that we have PDO, PLA, PDLA, PCL, KAHA, different in particle size, different in concentration, different in particle shapes. So how are we going to choose? Like, there are these factors that modified the inflammatory reactions. Like, first thing first, the chemical composition. As I mentioned, the chemical composition, I'm just gonna go towards the polyesters. So we have PCL, PLA, and PDO. So according to the literature, if you have a same particle size, if you have the same particle shape, usually the PCL can stimulate the highest level of the inflammation, followed by the PLA, and then followed by the PDO. This is one of the paper that it shows that in the PCL group, it has significant higher transduction signals for the TGF-beta and for the collagen production, and it's lesser in PLA group and in the PDO groups. Also the same thing, you can see highest number of the inflammatory cells in those PCLs. Polylactic is a big group. You have this lactic acid, and it connects as a polymers. But you have two types. You have those polylactic acid that the methyl groups turn to the right side. We call it dextro or D-lactic. And you have those one that the methyl group, the CH3 group, turn to the left side. We call it levo or left. So that's how you get PLLA or PDLLA. Okay? If you have PLLA, means that you have molecules that all of the molecules turn to the left side. Pretty much simple. PDLA, you have molecules that everything turns to the right side. PDLLA, you have something in mixture, randomly arranged. And there's a difference in terms of only like turning left and right thing, because these turning left and right molecules can actually result in a significant difference in terms of inflammation response. As you can see, if you have same thing, same size, same shape, kind of material, according to this literature, you can see that the highest level of inflammation you can find in PDLA. A little bit too high. That's why if you notice, there's no company as far as I know, at least in Thailand, there is no company that use PDLA. They only have PLLA and PDLLA because they're also smart. They also know that PDLA is a little bit too much for the normal tissue. Okay? And as you can see, PDLA is like excessive inflammation. And as I mentioned, excessive inflammation won't result in a good result for the rejuvenation. Instead, it's going to cause local tissue necrosis or even scar formation. Also, the difference of the polymers, different of polyesters have different time of degradation. This is something that you also have to take in mind. Okay, 2 minutes. Okay, the size. Okay, if you have something that is too small, the macrophage come and eat, and then it can cause like a high inflammation response, one single response. If you have something that is too large, the macrophage cannot engulf, like even though they form into a big giant cells, so they have to like release some enzymatic degradation. So you have to find something with a nice particle size around 10 to 100 microns. This is the sweet spots for the macrophage. Okay, I'm just gonna go really fast. I'm running out of time. I'm sorry. And then the morphology and the surface area. If you have like a spiky surface, if you have like a spiky shape, like irregular shape, of course it's induced more inflammation. It's irregular, it's increase in total surface area, so that's why it increase more and more of the inflammation. As you can see, the smooth surface has less inflammation, less cellular adhesion, and the irregular surface has higher in terms of inflammation. So when it's come to those polymers, you're going to need to talk to your distributor of the products. You had to see the real shape of the polymers, because that's going to affect the level of the inflammation that you're going to have. Almost finished. And then implantation sites. Yes, of course, if you put like something that with a high inflammation, you put it in the dynamic area, it will create even more inflammation response. So that's why some of the company, they advise you or they have a guideline not to inject in the dynamic area. So if you want to treat the dynamic surface area, you're gonna need to use something with low inflammation. And also the distribution pattern, you're gonna need something with a nice distribute, choose the right cell line and everything. So that's sum up for my talk. I'm so sorry. And yeah, just choose the right products on the right patient, and then you'll get like a nice result that you're looking for. Thank you very much. Sorry.
Thank you so much. Great presentation. Yeah, we have one more. Not you. Yeah.
Nora's all ready to present.
Next speaker is Itiphanipong Yada. Okay, is right pronunciation? Your name?
Almost.
From
Thailand?
Hi,
From
yes.
Thailand, yeah.
Good afternoon, everyone. So I'm Dr. Yada from Thailand.
Okay.
I am currently an adjunct faculty member in Chulalongkorn University. I work in the private hospital, and I have my own private practice too. So my topic today is going to be about the combination of the biostimulation for forehead rejuvenation. So moving on from like the complicated side, kind of like the more of the clinical application side here. Okay, so this is my disclosures. So when we see the forehead, why do you think that forehead is ages? Because of the lines, right? The forehead line, including dynamic and also the static lines. And the other thing is the volume loss here. That one is because of the bone resorption, muscle activity. The repeated muscle activity contribute to the dynamic line. We already know that. And that leaves the static lines as well. And after that, there will be dermal atrophy and loss of elasticity. That's why we perceive that forehead as an aging forehead. So we already agree, like we all know that botulinum toxin is the main treatment for the forehead line, and everybody use it for treating the forehead, which doing the forehead rejuvenation here, and also the HA fillers, which is considered to be the advanced injection for treating the forehead here. Okay, let's go back a little. Okay, but there is some challenge here because toxin cannot help improve the skin quality, at least directly. And the limitation of some HA filler, which is like delay onset nodules or like unusual lumps that happen later on. So the newer concept of the like right now we are doing like shifting into the biostimulation. So apart from treating just only the wrinkles, we have to add volume, of course, and we try to improve skin quality. Not only just skin textures, the skin radiance, but also in terms of like pigmentation and everything. And we try to, as all the doctors had already mentioned, we try to regenerate and revitalize our ECM or extracellular matrix. This is our goal here. So the biostimulation that I'm going to talk today is about the hyperdiluted CAHA, calcium hydroxyapatite, and the hybrid HA complex here. These are some of the literature that has been utilized hyperdiluted CAHA here for the forehead rejuvenation. You can use it like either like undiluted, diluted, or hyperdiluted. The hyperdiluted, the definition is that it has to be like at least or like more than or equal to 1:2 ratio. That one you consider it to be hyperdiluted. So these are the dilution that has been studied, and you can see that as the other professor and the other doctor has already mentioned, we can use like 1:2 or 1:3. Some of them for the face, they use 1:2. And it can, but however, it can be up to 1:3 for the pan-facial rejuvenation. And for the body, sometimes I will go up to 1:4, but mostly I will stick to 1:3 here. And when you treat a more superficial skin, or the thinner skin and darker skin, according to the literatures here, you have to use the more diluted one because it will help disseminate the medication very evenly. But if you dilute it like too much, they're gonna cause like edema that I'm gonna talk about too. The other one is the hybrid HA complex. It's the combination between high and low molecular weight HA here, and it helps with the bioremodeling, and it helps with the deep hydration and help rejuvenating like the ECM and everything that all the doctors already mentioned. Here is the studies doing the hybrid HA complex on the forehead. This is a study they use you know that one syringe normally that one company the most used one they have 2 cc in one syringe. This study they use one syringe like 1 cc like half of the syringe on the glabella and on the forehead and the other 1 cc on the eyelid area. And the technique that they used is the intradermal branching technique. It's mean like you were injected it like very superficially and you can see like some like branching and wheel stuff. In this study, they do like 2 sessions, 1 month apart. But however, the limitation from this study is that there are only 3 cases here. And you can see the result here. They claim that there is like the myomoderation effect because it can help with the lines. In these studies of these 3 ladies, they haven't get any toxin at all. And you can see the improvement in line even if you don't have any toxin at all. And let's move to another one. It's like the combination of the CAHA and cross-link HA. This is like in the one same syringe. that they use to treat on the forehead. This is the other brand here. But the good thing about this study is that there are like more sample size here, 111 patients, and the average injected volume was 3 ml. And you can see that they have like an improvement in terms of volume, loss on the forehead is better, and the lines on the forehead too. But however, there are some side effects that we have to keep an eye on, which is like localized hematoma, which of course can happen, and the periorbital edema. When you inject the biostimulator here on the forehead area, you can have the localized edema as well. So my concept is that normal, like I use a synergistic like combination between hyperdiluted CAHA and hybrid HA complex here. It's not a cross-link one, and I don't mix it in the same syringe. I just inject it in the same visit, in the same station, um, but different layer. So CAHA will work as a scaffold, and hybrid HA will work as a hydrator. So the scaffold and the hydrator, it will help rejuvenating the forehead very beautifully. And here you can have the patient who have like a lines on the forehead and the volume depletion. This is one of the photonumerical scale here that you can use, and you can grade your patients when you see your patient in the clinic. Okay, and when we treat the forehead, there is another paper that I would like to mention because there are differences in upper face aging depending on ethnicity and also on gender as well. So you can see that in male patient, when their forehead ages, eyebrows tend to be a little bit low set with a deep fold here, and male or like they're gonna have like a little bit more flat forehead compared to women. In women, eyebrow would be a little bit higher, and line would be not that deep. We already know that, but the forehead contour is a little bit louder. So and in these studies, they do order the ethnicity, and for African, South Asian, Middle East, they have a thicker skin. So most of their concern would be more on the periorbital area and all the pigmentation. But the complaint about forehead will come later on. But for East Asian here, we tend to we tend to focus more on like the radiance on the forehead. We prefer like a little bit like more rounded forehead for Asian patient. And in Caucasian, because of the skin is like thinner compared to like the rest, so the forehead line would come a little bit earlier, and this is the thing that you can address your patient when for the consultation. So this is how I do it. On the forehead, I injected the hyperdiluted CAHA here in the ratio of 1:3. I used to do 1:4, but 1:4 is like there are some like more eyelid edema that patient don't like it. And the other thing is the hybrid HA complex. I did like micro dot pattern, like branching technique on the forehead here. So when we inject, of course, it's like very like advanced area, and so we have to know the anatomical like anatomy and everything. So what we have to avoid is the supratrochlear and supraorbital artery, of course. And according to this literature, I think it's very good. They divide the forehead into it like 3 parts here: medial, a midline, medial, and laterals. So in that 2 parts, the pink and the blue one, and you go up, and we draw the dot line, like go up 19 millimeters above the orbital rim, that line. And then you can like do like the 3 parts there, and you will get that red area. That red area is okay to go like deep because the supratrochlear and supraorbital will like apart from like when you go like beyond that green area, it will go a little bit more superficial. Like we already know that, right? And the green area, it's okay to use the subcutaneous injection, but I myself don't do the green area at all.
Yeah, that
Huh.
already is time up.
Okay.
Please
Sorry,
hurry.
go there. Okay. So we like the injector, I do the hydrodissection, and do the cannula with the hyperdiluted kaha here, massage to the midline because I don't inject the midline under the glabellar area, and then I inject the hybrid HA complex and I massage it again. This is how I do the injectables. The hybrid HA complex here is like blanching technique. Here on the line, it's very simple. Yeah. So this is a before and after picture. You can see the better improvement, like improvement in the forehead here. And this is the improvement on the forehead contour. This is after 2 sessions. And apart from the volume, you can see the improvement in lines and the pigmentation. Yeah, like I don't expect the pigmentation gonna be this good, but it's very good. And this is a line here. Sometimes we cannot correct the static lines, but with the hybrid HA complex, we can help address the dynamic and static lines. And this is the last picture. It's almost the end of my talk here. This is the same women 5 months after the toxins. You can see that it can help increase like the toxin longevity. That one is actually toxin itself, but the other one on the right side is the toxin with the hybrid HA complex. And you can see that even if it's like 5 months, the toxin effects start to fade it out, but line is not as much as before. And side effects here, periorbital swelling, I already mentioned. Late onset complication, nodules from any biostimulators can happen. Vascular compromise, and according to study, you can do like the hydrodissection to kind of like decrease the risk of the vascular compromise. And take-home message, the forehead aging is different between ethnicity and gender. Women prefer a little bit more round, but male prefer a little bit more flat to make their like masculine. And injectable bioremodeling can help with the forehead contour, lines, and may increase the toxin longevity. And last but not least, short and long-term safety is a top priority for any injectables. Thank you very much.
Thank you, Dr. Yada. That was very extensive. And now I'm here to introduce my vibrant friend, Noura Leba from Milano, Italy. And she's here to exuberantly present on cutaneous biooptimization, combining injectable biostimulation with anatomical 8 points, lifting with classifier peptides PICULE, something that's new. Over to you.
Thank you so much for giving me your microphone. So, during this session, I will show you practical techniques, more videos, like you can go back to your practice with new insight, new videos. That's what I love to share, because we are here, we're spending our time to learn. We need to go back with something. Just to tell you that I'm practicing since 2009, since almost 17 years in Milan, Italy, as a cosmetic surgeon, and I'm a professor at the University of Genova. If someone wants to come to the Master of Aesthetic Medicine, you're more than welcome. So if you see my picture, oh my God, 18 years ago? I don't believe that. I love to use regenerative medicine, like conservative medicine. We never see my patient changing in anyhow. 18 years, I'm exactly the same. So that's what my patient wants from me, because we are not masking the aging. We are going toward natural regeneration. And we need to work on the five layer on the skin, from the superficial to the deep. No matter if you start from the depth one and to the most superficial, we need to work on all of them. So one of the most frequent treatment that I use is the botulinum toxin on the mesenteric, on the platysma muscle, because you see how it's one of the most important reason for sagging of the face, because it will drop off the fat toward. So here is one of my patients, like in 12 years ago, she was looking older than now, without any surgery. She's 72, actually I need to update it. And can you see her jawline? No face surgery has been done, and I will show you her picture. One of the the ingredient I use is non-cross-linked HA because it has been used since more than 20 years. It's absolutely FDA approved, CE approved, and we have a lot of benefits also, not only on the aesthetic part, but only on the medical part. So I love the HA, non-cross-linked HA, because it works as scavenger for the extracellular matrix. We talk about the healthy extracellular matrix, and this is very important. It works as an anti-inflammatory. Then I thought that I invented a technique, an 8-point, to strengthen the retaining ligament. What are the retaining ligaments I want to strengthen? The video is not going? Okay, so I want to work on the frontalis, I want to work on the platysma auricular fascia, the zygomatic ligament, and the mandibular ligament. We need to strengthen them because they are the anchored point of our fat. So if you want to avoid sagging of the fat to preserve a perfect jawline, we need first to stop the platysma, okay, and to have like as a preventive effect with the botulinum toxin, then to work and strengthen this retaining ligament with the fixed parts of our fat. So go ahead. So I will, of course, I will not inject too much the frontalis, honestly. I work with botulinum toxin on the top, but I will work on the other muscles. So I do one entry point, and I'm not using only HA, I'm using PRP, platelet-rich plasma combined with HA. One entry point with the cannula. I don't want trauma. I don't want a downtime for the patient. And I will inject 0.2 in base what I have, or even more. If I have more PRP, I can use more. And usually I can have until 5 ml. And I will treat also the tear trough ligament. So let's go ahead with only one entry point. On Asian patients, it works amazingly because they have already these heavy faces. We don't want to feel it. Sorry, I'm hiding you. Maybe I can move a little bit that you can see. Hide me. And you can see that effect. But the glow effect that you have, because I have worked with these spicules carrying peptides directly on the superficie of the skin because I want to work on the epidermal barrier, on the epidermal level. So here you can see on also the same patient, but what I love to use is, as I told you, HA with the PRP. You know the platelet-rich plasma, it mimics the normal healing, and it will induce the extracellular matrix to produce more collagen and more elastin. The plasma is also useful. Which kit I will use? It's very important. It needs to have, all the growth factors, of course, you have on your preparation, and it needs to have also separator gel because we don't want any red cells on it. The red cells are inflammatory, have an inflammatory effect, and they can give pigmentation. So the kit needs to be safe, simple, rapid, and reliable. And also, as I told you before, it needs to have separator gel. So here we can see very quickly the patient. In that case, I have used the antithrombin serum with a tube with antithrombin serum because I want to have this scaffold actually to make it last longer. So I will mix 0.1 of my part, which is like very solid, and I will mix it with the liquid one, the PRP, and then I will inject on the retaining ligament. And almost I inject sometimes even deeply on the bone. We talk about regeneration, even injecting deeply, and the result is a lot of glow on the face and a very important action of regeneration. So we can treat also the neck, we can treat different parts on the face. We can use also a cannula, or we can use also a needle. I'm treating also here the tear trough, but what I'm using, so the tube is already containing 20 milligrams of non-cross-linked HA, which is already mixed with our PRP, so in absolutely a closed system. What I combine with it, which is very important to combine, as I told you, I need to treat the superficial layer of the skin. Of course, you can use it for acne scars and other issues. So here, let's see. If you see this paper, it talks about epidermal barrier, the importance of the healthy skin barrier, that all the patients that I treat they need that glow. They need to use, so I'm using a glassifier, Korean one, you know how they are good in this type of product, and it's type of regenerative medicine, but with a very innovative way to deliver the product. So here we can see that if you apply the cosmetical, you don't have a penetration. So we found out that we can help with the penetration of the active ingredient with spickles. The spickles just with the contact on the skin. I have a special way to carry it. We have 1.5 million spickles, and we create microchannels until 180 microchannels. It is very interesting, the immediate glow that will give you, and it carries the GHK peptides, which has an important regeneration effect. Here, you can see how I do it. The technology is really very, very innovative because it doesn't have any downtime. The penetration is almost immediate, and the spickle will be released. And also the quality of spickle is important to avoid having any side effect. So let's see some results on the pigmentation, because we don't have only the GHK peptide, Cooper, we have also the glutathione and many other ingredients, and the result is really amazing also on the closing for the dilated pores, for the quality of the skin, regeneration of the fibroblasts. If you see some papers for some of the latest papers on the GHK peptide, that it has an anti-inflammatory effect, the angiogenesis, and it helps for tissue regeneration. And what about we are giving it without any type of injection, any type of trauma, any downtime? You can see another paper showing that the GHK peptide will enable the metalloproteinase response release of the diverse bioactive cargo. And here, how I do it, now I'm combining a PRP, platelet-rich plasma, with my glutathione peptide, glutathione booster, because I want to have that glow effect on the skin. So I combine PRP with microneedling, and then at the top I finish to have this glow. You remember this patient, which is 72 years old? Here we are together, and here I will show you. I combined the ultrasound immediately after, also with the glutathione with peptides, and you can see the glow on her face and how happy she is. Wherever treatment you are proceeding, whatever, they need that glow. Finish up, look her smile, she's happy, and you can combine it really with ultrasound, you can combine it with radiofractional macroneedling radiofrequency, and I want just to push to be please more creative and combine treatments based on the patient. Here are my painting. All of us as aesthetic doctors or aesthetic surgeon, we need to have a patient in front of us as a piece of art. Let's make the best. Let's combine the best product, the best protocol, and thank you so much for your attention.
Thank you, Dr. Noura. The spicules went to our brain also. You got us thinking. And yeah,
Did you try?
you're trying them in a local product,
Amazing.
topical product
Yeah,
for
exactly.
anti-pigmentation.
Yeah,
the
I will
spicules.
explain you how to use that better, even to combine with your treatment. They work amazingly.
Yeah, I think it's a good
For
concept.
acne, for even just like to give the glow, to close the dilated pore, and you're absolutely, you can use it at home also as a post-therapy, but combine in your practice, daily practice. All the patients, they want that glow. Whatever, if you give them filler, Botox, the final touch, use the spicules, and you really love it. I mean, the patient will love it more.
Which level do you deliver the spicules to?
That 2 millimeters.
2
it's
millimeters.
reached.
So
Yeah.
you're using the device comes with it, or you can use any
Without
device?
device.
Without.
Actually, I showed the part which can be used with the microneedling, okay? So the other part, you have the powder that you can mix with the Princip Active. Okay, you mix them, then just you apply them with your with your fingers perpendicularly, like to help the penetration of the spicules. So that you don't need any device with that. So I'm using it because I inject. Actually, I inject PRP, so I wanted to use just the liquid part containing the active ingredients. So not without the powder, without the spicules.
So your PRP is deeper and your peptides are going more
Exactly.
superficial.
So that's why you need to work on all the layers of the skin. This is very important. So don't think, and trust me, even if the patient will not ask you that for that, but after any treatment she does, that's proposed for her. You want the Korean glow, what I call it, whatever you want, but it will be, it's not only superficially that you will see the glow, it really helps the skin, it's regenerative because it contains lots of peptides. One of the peptides, GHK peptide, it contains also exosomes, it contains glutathione and other principles for, for skin brightening and treating also the inflammation for acne, treating the pigmentation and so on.
And how often do you tell them to do it?
Or you can do it once every 2 weeks for 4 times, for 5 times in base of that. But since the first session already, the patient will come, oh my God, my face is glowing, so they love it. I will tell you the name, the commercial name. I'm not
Offline.
Yeah, no, I'm not allowed maybe to say commercial name, but the name.
I think we can keep it offline. But
But I
Doctor,
will
you
show you
are
later.
yes.
Yes.
Please go ahead.
I would like to open the floor. Somebody, any question, please, on the mic and asking. Okay.
She's from India.
Hello, Doc. I have a question for you. I'm also using the same kind of microspicules which you're using.
Okay.
Yeah. So I wanted to know how, like, once you apply that, how long do you ask the patient? So because we use the locking cream post that, and when is the
So
patient?
if you said locking cream, it means that you're using Edenel.
Yes.
Okay.
I did not want to speak about it. It should be offline.
I didn't want to tell you to say the name, but
So yeah,
Because
so the
they do-
locking cream.
Yeah.
So how long the patient should keep it for? Because
oh, it's better at least for 2 days, okay? Because these channels will be open for a bit. So ask your patient, avoid makeup, avoid anything like not just the locking cream, nothing else for 2 days, okay?
okay,
Just for 2 days.
or any
And-
other
and
precautions specifically for doing any procedure post that? How long should be the gap between? Because what the patients have experienced.
She
is-
feels like speckles. She has speckles. When she touched her face, I did
Yes,
it also for
other-
myself.
Yes.
Yeah, she feels that speckles. Oh my God, it hurts. What is it? And she remembers that we did it.
Yes.
Okay, that's fine. You can do anything you want. Of course, no peeling, no chemical peeling immediately after in the next 3-4 days at least. Remember, when you apply them, you shouldn't scrub the skin, right? Just like
Yes.
apply it perpendicularly, like with that very smooth movement. And that's it. No, I mean, she can do whatever she wants, but just no chemical peeling, no tretinoin, for example, no retinol, like nothing which can a little bit irritate the skin. Because they create micro-inflammation, which is positive to stimulate the collagen, you know?
Yes.
So no over stimulation of the skin.
Okay. Thank you.
You're welcome. Where are you from?
From India.
Ah, India. Nice to meet you. You are already in India? They came in India themselves? Oh, I didn't know. Fantastic.
We have it, yeah.
Maybe you know it.
Yes.
So you have question?
Yeah, Dr. Ting Song. So eventually, after all these lectures that you've heard, and you gave a beautiful lucid talk on the ECM, what do you think really is the strategy? What should be the strategy? What do we want to tell?
I think we try not to hurt the matrix by overstimulating them. We want to preserve and make them healthier. So giving them nutrients, giving them ways. There are any energy-based devices that vibrates them. When you vibrate the connective tissues, it becomes healthier. Of course, stimulate muscle stimulation helps that as well. And also, I personally feel that the whole trend of biostimulation will come down very soon, where we start to see more and more complications, nodules, fibrosis, and also expedited
See
aging.
them already, you know,
Yeah,
with
exactly.
the hydroxyapatite calcium. So to be honest, and I saw them like 20 years, patient 20 years ago that I treated the neck, and she came to me, she said, oh, I have a nodule, what is it? I did ultrasound.
Exactly.
I
We've
said,
used PLA since
I didn't
the
tell her
early
it could
days.
be CA. I didn't
Yeah.
want to tell like
So one thing that I also have to emphasize is that aging itself is not due to tissue loss. Don't fill it up, because it's the tenting of the tissue we need the space inside. If you stuff too much things into your tissues, you, you compromise that space, and your connective tissue doesn't work the same way anymore. So don't stuff things inside just because you think that they have volume loss and thinking the best way to fix it is to put things in there. Let them heal. Let them have that space to move around.
Just one very small, sorry, go ahead.
No, go ahead.
So extracellular matrix, it's like the ocean where the fish, which are the cells, live. So it needs to be healthy. You need to give them
Exactly,
space.
but the ocean doesn't have the water. In between are all empty space. We call it interstitial space, and that space is very important for things to flow.
A little bit explain about that is because I'm a plastic surgeon, so I commonly did facelift operation. But when I was residents, we don't have a choice. Come to the clinic or hospital, we try to operation. But nowadays is operation is less and lesser. Because is Ching Song Min explained about one thing very impressive. They explain even though apply the material inside, lesser make a trauma, because is we try to we reflect our patient is only during life only one facelifting operation, 2 times facelift operation, 3 times facelift operation. Yeah, maybe disappear wrinkle, disappear maybe shape, disappear the sagging, but it look like the wax face because the skin is thicker. Meaning is not actually skin is thicker because inside the fibrotic tissue is developed. So is he mentioned about this kind of idea. I think I heard first recent from 2 years ago. He started in Malaysia, introduced about that. But yeah, that is very important. Even though nowadays is many people is is injection, sometimes hyperdilution injection superficially. They don't also make a trauma, even though we have to thinking about elastic fiber make a fragment. So more aggressive treatment is non-maker rejuvenation. Sometimes we make more is unnatural, more is broken the nature. So one more thing is because is nowadays Korea is very popular using the collagen. So before Ching Song Lim introduced about the low eyelid rejuvenation, he prefer using the. I know he prefer using the PN, but I want to ask him between the PN and collagen. Now, which one is more easier for us, and also is make easily make a good result?
Right, I think they don't replace each other. What we see right now is the best way to restore ECM is give ECM replacement therapy. We talk about ADM is replacement, but more importantly is the component. Polynucleotides are a chain of nucleotides. They work on the nucleus to stimulate our nucleus to produce the raw materials for all proteins, because all cellular matrix, extracellular matrix, are built by proteins made from the nucleus. And the raw materials, if you look at all the RNAs, DRNAs, they are nucleotides. They are polynucleotides. And basically, when we give these raw materials, they actually produce proteins out of it. So that's one. You can give collagen because they are actually proteins that made of raw materials. And we know that these proteins actually sort of, we call it the collagen replacement therapy. Again, it itself, some of it attached to the collagen and do things. It's almost, you can see just now when they actually start moving around, they actually sort of have movements, but they also need raw materials in there. What we're supplying is the raw materials for our tissues to use them. That's the whole concept. But then again, if we use collagen as a filler, that's where we did everything wrong. And one thing I have to say, yeah, you're correct. Sometimes scar tissue, we don't see it. A lot of tissue retraction seems like it's tightening. It's all scars. But these scars hampers a lot of energy flow. In the end, we are not doing our body a service. We are actually causing more damage.
But I was thinking, why not using molecules that exist since years, like HA non-cross-linked, that we already have in our body?
Exactly.
PRP, like
Yeah.
based like
But there's also
the
limitation
base scientific.
because HA are actually part of the glycosaminoglycans. Too much HA in the system can glue everything together.
Okay, I
So
agree. But like just right amount.
hydrating
Amino
is
acids
good.
also we need them, right?
Yes,
They
so
compose
those are
our
good ones.
collagen.
Amino acid, a little bit of HA, a little bit of everything works better. But if you just do one thing and put too much, it's also not good.
I agree.
PRP helps platelets, but they are not the major component inside there. They are actually
Like we will
sometimes.
use the growth factors of the PRP combined with the HA, which is.
You can do that.
But
yeah.
the HA, because we stimulate the fibroblasts to produce more. It's not there
Exactly.
just make space, you know?
Yes.
It's autologous. It's type
Yeah.
of autologous. I think she has a question.
Thank you so much, Dr. Nora, for delivering such an amazing lecture.
Thank you so much.
I wanted to ask the microspicules you talked about.
Yeah.
Do we have to apply them after procedure, or did you use them with microneedling?
Okay, so the spicules themselves, so if you mix the powder with the product, absolutely you don't need to use, you can't use them with the microneedling, which is us already, they will veiculate our princip active, you know, GHK peptide and so on, what we have. Then if you want to use microneedling physically, if you're already using like a PRP with something, another product that you want to mix, you use only the solution. Okay, got it?
Okay.
So you don't use it with microneedling. No need of microneedling because it was to replace the microneedling.
Okay.
In somehow, you know what I mean?
Yeah, I get
Okay.
it now. Thank you so much.
And of course, if you if you treat the patient with the energy-based device, which has contact with the skin, you use them after, of course, because you can't use anything to rub the skin after applying the spicules. We don't say we apply the spicules because we need to not to rub with it, but to
Pat it.
yeah, exactly, to pat it. Thank you so much. I guess you're from India.
So,
Pakistan.
Okay. We already is past time, so one more question to the pretty ladies. So during the biostimulator, usually stimulate the increase the not only collagen, increase the lipolysis, is a fat growth. So maybe all of among you have any more study about usually is fat is we can classify two different kind. One is gray and one is white. So with the lipogenesis, during lipogenesis, have you ever study about which one is more growing or which one is more decreased? Which part? You know, is still only just the growing the fat generation, something?
Because I think that actually the fat cells or a mature adipocytes cannot differentiate by itself. But what we have, the evidence is only the in vitro study of the stimulation effects on the pre-adipocytes, okay? But the clinical impact is that, and how do we change from the pre-adipocytes into the mature adipocytes? We need more of the cytokines, peptides, other factors that can change the pre-adipocytes into what we need. And actually, all these signals are lower when we're aging. So that means that now we have some of the evidence that it can do like this, but in reality, how it can do, how better it can do, we need to study more.
So you mean is it does not lipogenesis, right?
It
We
can,
cannot
it
say-
may, yeah,
we
maybe.
cannot say
We cannot
exactly
say exactly, yeah.
uh,
I believe there is a clinical trial because they call a SPLASH clinical trial for the PLLA on the adipogenesis. You can read about
Okay.
read more.
Yes, I have to say otherwise. Yes, inducing the precursor cells, yes, but there's a term called the white to brown polymerization. Basically, you have two kind of fat cells. You have those white fat cells. Basically, the color, the white, the beige color, the gray color is the color of the mitochondria. So the more mitochondria you have in the cells, it's called the beige, brown, grayish color of the fat cells. So this phenomenon from white to brown, actually, if you have cells, imagine you have cells with inactive mitochondria, the cell is fat, it's not active. But once you turn these white fat cells into the brown, gray, beige, no matter which color, these fat cells, it's more active because the mitochondria acts more, it's more active. So this phenomenon can be seen with PN. There's a study using PN, and it's confirmed that it induces these thermogenin receptors on the cells, on the adipocytes, and it's turned the white adipocyte into the brown adipocytes.
Yeah, why I ask about this one is now I study about with the peptide. It's one of the peptide using the for the fat rejuvenation. No, no, no. It's you mentioned about the mitochondria, so that is correct because we produce new progenitor peptide, lipid. That is most of the produced gray fat. Even though is also is for example between me and her is my dominant fat is white fat. Her dominant fat is gray fat. You know, so is we try to make her we stimulate the lipogenesis. Is most of the time is gray fat because it's active. So I, oh yeah. So that's why maybe I did the study about peptide, but I did not study about is biostimulator. Kara is so maybe you're working in the hospital. So maybe if you can, please study and explain next time. Okay?
Yes, I have a plan already.
Yeah. Thank you. Great. Yeah. Please, you add something. Why? Yeah. Thank you so much, everybody. Thank you.